Good evening, everybody. Can y'all see my slides?
Yes.
Okay, great. All right. It looks like there's a good number of y'all on, so let's go ahead and get started. I'm Dr. LePage, and tonight we're going to talk about pharmacology for infectious disease, kind of focus on a lot of our different types of antibiotics. So, as far as our objectives, we're going to apply the nursing process to the administration of antibiotics, antivirals, all of our different anti infectives. And it's for those patients who are affected with or by infectious disorders or diseases. We're going to talk about the mechanism of action, contraindications, side effects, and then most importantly, the nursing interventions and what are we going to educate these patients on when they're taking these medications. And then verbalize the use of the different medications and the pathophysiology of them. So, infectious diseases, they are classified. Most of our medications, or a lot of people want to call them antibiotics. I say that's a very broad term because they each work differently. They are antimicrobials or anti infectives, but they target specific types of organisms. So your antibiotics are going to fall under several different classifications. And two things to remember is they're either narrow spectrum or broad spectrum. So a broad spectrum antibiotic is going to kill off a wider range of organisms. Our narrow spectrum are particularly geared for specific types of organisms and specific types of disease processes. So, how do we know the difference? When a patient comes in, we need to put them on an antibiotic. What is that for? So we typically start, especially if they're a septic patient, because we all remember that blood cultures take 24 to 48 to 72 hours to really decipher what medication is the best for the particular type of organism that that patient is presenting with. So we put them on those broad spectrum antibiotics. And then once we get or start to get the cultures back, then the physicians will adjust the medications to those that are more targeted and narrowed for those medications. So those would be your narrow spectrum. The antimicrobials treat those infections that are due to bacterias, viruses, or funguses. So when we're talking about bacteria, we're talking about our antibiotics, our penicillins, our cephalosporins, our macrolides, our sulfonamides. When we're talking about viruses, we're talking about our antiviral medicines. When we're talking about particular fungus, we're talking about antifungal medications. And then we have those antiparasitic medications that work on the worms and the different types of GI dysfunctions that patients present with. So, what are some of the factors that determine what's the type or the best type for this patient? Well, first off, we got to identify the causative agent. Is it bacterial? Is it viral? Is it fungal? What exactly is it? And then sensitivity of the organism to that microbe. What medication is going to be the best for this patient? And then where is the infection? Because some of our medications and our antimicrobials don't work on the upper GI, but they'll work on the respiratory tract, or they work on the colon and not necessarily the gastritis or the upper respiratory. There are particular medications that work just specifically for vaginal and female issues, and then for your STDs. So it's a wide range, and students like to always say antibiotics, and I try to get students to narrow down what is the actual classification. Is it a sulfonamide? Is it a macrolide? Is it a cephalosporin? Is it a glycopeptide? What does it actually do? Because that's going to help you better know what it works on and what disease process we're treating. So when the physicians are ordering these different antibiotics or antimicrobials, they have several different things to consider. What's the patient's immune system like? Because those patients who have intact immune systems, the antimicrobial drugs are going to work with the host defense system and they're going to fight off that infection. If a patient has an altered or a decreased immune system or a suppressed immune system, they're not going to work as good, and they might need more, or they might need a longer course, or they might need more than just one antibiotic. They take into consideration the site of infection, like we just talked about. Depending on what antibiotic it is or antimicrobial, where is that infection and what works best on that part of the body? What is the age of the patient? A lot of our antimicrobials are very nephrotoxic and hepatotoxic. So if we're talking about an older aged patient, we already know that their liver and their renal systems start to decrease in function. So this medication can build up. It won't be excreted. It won't be metabolized. And these patients may need smaller doses or dose adjustments. Pregnancy. we've talked a lot about everything is contraindicated in pregnancy, right? So we really need to watch what we're giving these childbearing age women, and are they pregnant or not. Sometimes they may have to get a pregnancy test just to confirm a negative, make sure that they're negative before they prescribe them. And then, have they had previous allergic reactions? Our patients who are typically allergic to penicillin have a cross allergy or sensitivity to cephalosporins. They also have a allergy typically to sulfonamides as well. So we really need to take that into consideration. Combination therapy, again, we may be needing two different types of medication. We use two different antimicrobials for a lot of our STDs that are treated. They might get that Zithromax, or they're going to get that Zithromax and then the Rocephin as well. And then prophylactic. We talked about cardiac issues in the past couple of weeks, and patients who have endocarditis or some of the valve replacements, or if they've had childhood diseases that have affected their heart, they may need prophylactic antibiotics for dental work to prevent those infections. So there's a lot of little factors that, not so many little, but a lot of factors that go into consideration when the doctors and the physicians are prescribing them. So, what are some general facts? Most of them cause a lot of adverse reactions. It's just the way it is. But do we not give them to patients? No, we give them to patients, but we use them with caution. There's a lot of cross sensitivity. Like I said, the penicillin and the cephalosporins, and the penicillins and the sulfonamides. A lot of these antibiotics cause some major super infections. So now we're treating them with an antibiotic for the original infection. They develop these super infections. So now they're on those antifungal medications to treat those super infections. Organ toxicity, particularly the hepatic and renal organs, again, are older adults. And then most often the side effects are nausea, vomiting, diarrhea, and rash. Antimicrobials cause a lot of GI upset. One of the minor super infections is going to be that thrush that's associated with a lot of antimicrobial use as well. And then most of these need to encourage a lot of fluids for these patients so that they can aid in the excretion of them, especially our older adults. And then one of the biggest things is we all educate and we tell patients it takes about 24 to 48 hours to start feeling better. And then what happens after a day or two after that? These patients start to feel completely better and they stop taking the medication. And the reason the medication works is because it's fighting that infection. But if they stop it, they have a chance of having what we call a rebound infection, where it comes back twice as bad as what it was. So, antibiotics that affect the bacterial cell wall, that means they're bactericidal. We have two different types, bactericidal or bacteriostatic. And we want them to kill off and affect that bacterial wall and get rid of that medication. So, how I remember the difference between what the bactericidal do and the bacteriostatic is your bactericidals are going to kill off, and C comes before S when we look at the words. The bacterial static are just going to stop the replication. So it doesn't kill them off, it just stops them from replicating. So what do we want? We want them to go away, be gone, and essentially die and affect that bacterial cell wall so that they can't replicate. So that's our bactericidal versus our bacterial static. So some of those classifications that are bactericidal are your penicillins, your cephalosporins, your carbapenems, and your monobactams. So let's talk a little bit about penicillin. Have any of y'all had to administer penicillin, particularly penicillin G? No? Well, it's very thick. It does come in the pre-filled syringes most often, and we use them for several different STDs and a lot of our upper respiratory infections as well, particularly strep throat as well. So it's very thick. So when you administer it, you feel it's kind of hard to push in too. And it's kept in the refrigerator. We use it for a lot of our gram positive bacteria, a lot of your streptococcus um, organisms, pneumonia, meningitis, infectious endocarditis, pharyngitis. Again, the tonsillitis and pharyngitis, strep throat. We do administer penicillin G, typically or penicillin V, the PO type, prophylactically for dental procedures in patients with a history of endocarditis. Again, it's contraindicated in pregnancy, renal disease, and then that cross allergy with your cephalosporins. Some of the side effects can be renal impairment. We see a lot of rashes with penicillin and sulfa medications. These patients do develop often, frequently, super infections, and they complain of taste disturbances. So they're really hungry because they're trying to mask the taste and they're not able to taste what they're eating. So they wind up eating a larger amount. Sometimes it's associated with a little bit of weight gain. Some other side effects are hyperkalemia and hypernatremia. So the hyperkalemia, if we remember what we were talking about with EKGs, we were going to want to monitor this patient's cardiac status as well. There are interactions with aminoglycosides and oral contraceptives. If patients are taking penicillin and on oral contraceptives, we need to educate them that they need to use some other form of barrier protection if they do not want to get pregnant, because it's going to decrease the effectiveness of the oral contraceptives. Some of our nursing interventions, definitely they want to take the entire course, take it with food, drink plenty of water, good skincare because it can cause rashes and dry skin. Also, avoid direct sunlight, put sunscreen on, and then monitor those electrolytes. If they develop allergies, we need to educate them to wear those allergy bracelets and then monitor their I's and O's because of that um, renal toxicity and that renal impairment. So our macrolides, they're going to slow the growth of the microorganisms by inhibiting that protein synthesis. So they're going to stop them from growing. So they have those bacterial static properties. That's going to be your azithromycin, the Zithromax, and clarithromycin, the Biaxin. We use it for patients who have allergies to penicillin, chlamydial infections, urethritis, cervicitis, some of those STIs as well, and then streptococcal infections and pneumonia. Again, you'll see it's contraindicated in pregnancy, and your macrolides, especially patients who have a prolonged QT interval on their EKG. If you remember when we were talking about that R on T phenomena, these patients that just fall out and drop dead is that R on T phenomena. We see that a lot, and that's due to that prolonged QT interval that they may not be aware of until either something happens or they go for a routine visit. We see it a lot with athletes when they get hit with a ball, especially in the chest, and it'll just put them out. And it's basically like a thump on that that prolonged QT interval on that R on T phenomena. Some of the side effects, again, are your GI upset, epigastric pain, and vertigo, as well as ototoxicity and ringing in the ears. So we really need to monitor these patients' hearing and ask them if they're having any of those side effects. The macrolides that can interfere with these medications, I'm sorry, macrolides can interfere with warfarin and cause a prolonged PT and INR. So we need to monitor these patients for increased bleeding. Educate to complete the entire course, administer with food. The oral prep of azithromycin needs to be taken 1 hour before or 2 hours after eating. Again, increase their water intake. And if it's used for those STIs, we need to educate them to avoid sexual intercourse while they're taking the medication. And then their partners need to be treated as well. Some other interactions are going to be with their antihistamines. Theophylline is aminophylline, and that's used as a bronchodilator and with asthma. Carbamazepine, and then, as you can see, the warfarin as well. And then erythromycin is going to inhibit the metabolism of the medications. Verapamil and diltiazem, again, is going to inhibit the metabolism of erythromycin. So it could lead to toxicity and tachyarrhythmias and then cardiac arrest, unfortunately. So we really need to be monitoring these patients. Any questions so far? I have allergies, so you can't.
I have a question, Professor.
Ma'am?
I said I have a question. Hold on.
Sure.
I already down. 1 second, please. So what would be the example of because you said the minor superinfection like candidiasis. So what would be the example of the major superinfection?
I didn't hear the whole question. What would be an example of what?
Major superinfection.
Major or minor superinfections? Well, your major superinfection is going to be your C. diff.
Okay.
One of your minor ones is going to be that candidiasis or the thrush.
Okay,
We can manage that a little better, right? They may need a dose of diflucan, or actually, too, with women, they get the vaginal yeast infections with antibiotics. So they may put them on a dose of diflucan, the antifungal. Does that help?
Yes, it does. Thank you very much, Professor.
Okay. You're welcome. And then your cephalosporins. So they're similar to the penicillins, which is why there's that cross sensitivity. They're going to destroy that bacterial cell wall, causing the destruction of the microorganisms. They are considered broad spectrum. So a lot of times, ceftriaxone, the Rocephin, if patients come into the emergency room with sepsis, they're getting azithromycin and the ceftriaxone, the Rocephin. Maxipine is another very strong antibiotic as well that we use for sepsis. We use it for strep throat, UTIs, minor ear infections, lung infections, meningitis, and, as I said, the sepsis. Again, contraindicated in pregnancy, and make sure you're watching for those cross allergies to penicillin. They do interact with several different medications or substances, such as alcohol. It's going to intensify the alcohol, and it's going to decrease the effects of the antimicrobials. Probenecid and colchicine delays renal excretion. And then calcium and ceftriaxone causes the solutions to precipitate and can cause some complications. And if we're having precipitated calcium, it may lead to kidney stones. So definitely need to be monitoring these patients. Side effects: the cross sensitivity to the penicillin, urticarial rashes, it can cause some hypotension. And then I put there with some of your specific medications, you can see the cephalosporins, if they're given IV, can cause thrombophlebitis. So how are we going to prevent that as nurses? How are we going to prevent that thrombophlebitis? Good assessment skills, right? Monitoring that IV site, monitoring for any deep vein thrombus. I see somebody put in here, do you give out copies of the topic? Yes, the slides were posted. They're typically posted within the hour before the course starts or the session starts. Monitor that IV site, absolutely. Any slight redness, any pain, we definitely need to be very vigilant to see what's going on. Nursing interventions, monitor for allergic reactions. If we're giving it an IV infusion, it's going to be very slow, and monitor that site frequently. If we're giving it IM, we're going to rotate those sites, monitor their renal functions, and monitor for any irritations as well. And then again, monitor for that C. diff, which is one of the major super infections. And C. diff is pretty frequently seen with some of your cephalosporins. Your fluoroquinolones, your fluoxetines, they fight the action of what they do is, and what we use them for is to fight life-threatening infections or those complicated infections that are resistant to the other medications. And they work by inhibiting that DNA replication. They are the first line treatment for prostatitis and some of your GI food poisoning organisms. You can see we can use them for a lot of different things, pretty much head to toe, right? Sinusitis in the sinuses, upper and lower respiratory infections, renal disease, and then prostatitis, bronchitis, and UTIs. So your fluoroquinolones are hitting all your major organs. Those are going to be your Levaquin and your Cipros. Again, the same kind of side effects. These medications tend to cause insomnia and anxiety in the patients, and also elevate their blood glucose levels if they have diabetes. So we definitely need to be monitoring their blood glucose levels frequently and keeping an eye on that so they're not going too high. Some of the other very common side effect is a spontaneous tendon rupture or tendinitis. So if these patients are athletic with big muscles, those tendons tend to rupture, and those can be painful. Nursing interventions, again, to avoid that direct sunlight, maintain and increase water consumption. They can take these with food, but they need to avoid calcium, zinc, aluminum, and iron because they're going to decrease the absorption of the medication. So if they need to take those supplements, they need to be administered 2 hours before or 2 hours after. And where do we see calcium, aluminum? In a lot of antacids. So that's why we need to educate these patients. Any questions? Our sulfonamides are going to be bacteriostatic, and they're metabolized by the liver and excreted in the kidneys. So what are we going to need to monitor? Definitely the renal and the kidney function, right? Monitor the good urine output on these patients. We use sulfa oh, it is a sulfa based medication. It's a cream. We use it for burn patients, and the name of it just went out of my head. I'll think of it, I'm sure, before the end. Burns, we use a lot of sulfa based ointments. Vaginitis, we use vaginal creams. And we use them for ocular infections. They can be in drop form as well. Your Bactrim and your asulfidine. The thing with your sulfonamides, they cause a rash. A lot of times, rashes with our medications occur on the first or second dose. What makes the sulfonamide stand out or be different is these patients can be on it for 2 weeks and then we notice the rash, or they notice the rash. The rash can be very severe, and then they often need to be seen and treated for that rash with the corticosteroids. The other thing with the sulfonamides is it can cause Steven Johnson syndrome, which is a severe systemic skin disorder that causes aching, blistering, and these patients' skin just peels off. I think I've mentioned it before. When I worked ICU in the 90s, I had a patient who was African American, came in with Steven Johnson syndrome, although hers was due to hair products. And unfortunately for her, that she did not survive. Her skin would literally just peel off. And the poor thing, it does lead to organ dysfunction. I mean, she just went to go get her hair done, and something in the hair products, which everybody was saying back then, that was my first. I've seen Steven Johnson syndrome since then, but that was the first I'd ever seen it and the worst I've ever seen it. She wound up on life support, and she was only in her 30s, had small children, and she looked white. She was an African American person, and her skin just peeled off. You know how snakes shed their skin? That's what she was doing, and there was no pigment left before she died. So that was about the saddest case I've ever seen. Can cause photosensitivity, anorexia. There are drug to drug interactions with digoxin, can lead to digoxin toxicity. Warfarin can increase that bleeding time. And Depakote and methotrexate, the sulfonamides, will decrease the effects of these medications. So, our nursing interventions, the first time or the first indication of a rash, stop the medication and be seen. Provide safety due to those CNS effects of dizziness and lethargy. And then again, administer it with foods. Any questions?
Do we need to monitor for bleeding?
Repeating what, ma'am?
I mean, you tell that it has the drug in to drug interaction with the warfarin. So do we need to monitor for bleeding?
Yes.
And we need to use the sunscreen before getting out of the house, yeah?
I'm sorry, repeat that.
The sunscreen.
Yes.
Okay.
Any of the medications, when we want to educate the patients to avoid sunlight, they probably shouldn't be going to the beach and sun tanning. They should be wearing sunlight. I'm sorry, sunscreen. So our glycopeptides are our myosins, and how they work, they're used to treat some serious infections that are resistant to other forms of antibiotics or antimicrobials. Your vancomycin, we consider that the big guns. When these patients come in with sepsis and they're put on the broad spectrum antibiotics, it's typically vancomycin and zithromax. If they can't tolerate the vancomycin or they're allergic to it, they're put on Rocephin. They work by binding to those double DALAs. So you see DALA and DALA, those strands, and then they're going to permeate the cell membrane to inhibit the peptoglycan synthesis, which is then going to disrupt the cell wall and inhibit that bacterial growth. So that was just, I thought that was a cool schematic or visual of what the action does, and that pretty well explains it. We use them for MRSA, endocarditis, enterocolitis, pneumonia, those severe skin infections, and of course, sepsis. The thing with vancomycin is it's very renal toxic. It's also hepatic toxic, but more so renal. Your mycins are going to be renal toxic, neurotoxic, and ototoxic. So, if you've ever heard the little ditty, Three Blind Mice, can't see, can't hear, can't pee, and then they're confused. It does cause red man syndrome. So, one of the interventions we're going to do, these patients, when they're getting vancomycin, it's often because the vancomycin is being infused too quickly and their face is going to get really, really flushed and very, very red. That's why it's called red man syndrome. We need to lower the medication rate or infusion rate and then monitor this patient. If it does not go away, we need to discontinue it. Or if they start to develop a rash. Can cause some muscle spasms, hypotension, and then your normal shortness of, well, it's not normal, but the signs of adverse reactions, the shortness of breath and itching and skin rash. With your vancomycin, we do what we call peak and trough levels, and that's to measure that renal function. A lot of times patients, we monitor the renal functions before they're even started on that vancomycin. Number one, we have a starting point or a baseline, and then to see if it's worsening it. If their renal function is poor to begin with, they may not be able to be started on the vancomycin. We do the peak and trough. The trough level is drawn 30 minutes before the third dose of medication. And then we draw the peak level 30 minutes after the third dose. So if the infusion runs for 90 minutes, we're going to do it 30 minutes after it stops. And there are specific levels of where it should be, their serum. So it's blood work and it'll have the actual levels. Off the top of my head, I don't know what they are, and I doubt that NCLEX would test you on those levels. And what NCLEX is doing with all of the lab work now is they're giving you the normal ranges. So you just need to look at the patient's value and then what is the specified normal range that NCLEX puts on the exam. Any questions so far? When do
Does
we
it
do peak and
does it
trough
provide
levels?
normal range on the
We
every
do peak
patient's?
and trough levels. Your trough level is going to be 30 minutes before the third dose, and your peak levels is 30 minutes after the completion of that third dose. What is the medication for also? Vancomycin? Is that what you're asking? No, I said NCLEX give it to us in the exam. Give what to you in the exam?
The levels.
Yes, that's what I said. They'll give you the patient's level and then they'll give you the normals on all the blood work. So basically, you just need to evaluate, is that normal, abnormal, and then if it's abnormal, what does that mean? Sometimes they'll give you what the medication is for. Okay, well, that's making it easy. All right. So our antivirals, they're going to prevent the reproduction of the viral DNA and interrupt the cell replication. So antivirals are for viruses. A lot of times, parents will bring the kids into the ER because they're sick, they got a fever. We determine it's a virus and they still want antibiotics. Well, there are no, that's not good because then patients develop antibiotic resistance. So when they actually need it, it's not going to work. And antimicrobials, antibiotics don't work on viruses, and there's only particular viruses that they do work on. So we use these antivirals for your varicellas, your zosters, and your cytomegalovirus on your patients who we typically see cytomegalovirus associated with HIV. Flu and influenza is oseltamivir, which is Tamiflu, and the window to start that is within the first 48 hours of onset of symptoms. If they've gone 3 or 4 days and still having symptoms, the medication is not going to do any good. Probenecid is going to decrease the excretion of acyclovir, and zidozuvine and your antivirals increase the incidence of drowsiness. So you really need to be monitoring these patients and looking and doing good medication reconciliation. Some side effects of your antivirals are going to be phlebitis and inflammation at the infusion site. They can be nephrotoxic. They can have some GI side effects and bone marrow suppression. So, as far as our interventions, if we're giving it IV, we need to monitor that site. If we're giving it IM, rotate the sites. Administer the infusion over 1 hour, and then monitor those renal functions. Increase their PO fluid intake and get a baseline CBC and platelet counts. And then these patients need frequent monitoring. They can look at the CBC, the differential part, to determine whether it's a virus or a bacterial infection. Your antifungals are going to end in ZOLE, and they work on the fungal cell membrane to cause death of that cell. Your fluconazole and your miconazole, your monostat, your diflucan. We use it for fungal infections, aspergillosis, ringworm, tinea pedis, and then your nail bed infections, which are all fungal infections. You see the interactions with gentamicin and streptomycin. Again, remember your mycins are nephrotoxic. The antifungals are going to increase the levels of the digoxin and warfarin. So it can cause digoxin toxicity and bleeding, increase their bleeding time. Some side effects are chills, fevers, rigors, thrombophlebitis, electrolyte imbalances, nephrotoxicity, and bone marrow suppression. We want to monitor for fever, chills during the infusion, rotate injection sites. We want to give it if it's IV through a large vein. Monitor again their eyes and nose and increase their fluid intake if it's not contraindicated. Our tetracyclines are going to treat bacterial infections, particularly your chest, respiratory infections. They do work on some pelvic infections, the pelvic inflammatory disease, and a lot of your inflammatory skin infections like rosacea and that perioral infections. So doxycycline, minocycline, and tetracycline. Side effects again are going to be the same: nausea, vomiting, and diarrhea. Your tetracyclines tend to cause a black hairy tongue. And it looks, if the patients stick their tongue out, it looks like cat hair. It looks like the back of a cat. I'm not a big cat lover, so it's kind of gross to me. They develop sore and irritation in their throat and then blurred vision. We want to monitor these side effects. Again, tell them to take the full dose and monitor the liver and renal function. Does anybody have any questions? It was a rapid fire overview, right?
Do you have any example for that? For a tetracycline?
Examples of what? The types of medications?
Mm-hmm. I mean,
Yeah, right.
except there are three. I mean,
Right there. Doxycycline, minocycline, and tetracycline.
I mean, the topic is also a tetracycline, and the medicine name is also tetracycline. I mean, is there any typical name?
You mean the brand name?
Yeah.
I would have to go back and look it up. I don't think tetracycline has a brand name. Doxycycline, NCLEX will give you the brand and the generic name. Let me look it up for you. I only know it is doxycycline. I'm not finding doxycin, Oratia, or doxycycline. Yeah.
Also, mostly in the NCLEX, the example they use is the doxycycline or tetracycline. It's still the same thing.
Your mic is kind of muffled.
Professor, with the
What I was trying to say is mostly in the NCLEX, it is either doxycycline or tetracycline. Tetracycline is still a brand name of medication.
Tetracycline is the classification, but it also has a tetracycline in it.
Tablets, yes.
Yeah. Somebody put in there, don't worry, NCLEX will give you both. Yeah, NCLEX does give you both. But NCLEX is going more to the generic names. I saw somebody else getting ready to ask a question.
It was perfect. I was just going to ask that with the tetracyclines, I have something written down that just says, do not take with milk, antacids, or iron supplements.
Correct.
Okay, as they bind to the drug and it decreases its effectiveness.
It can.
Oh, it can. Okay, thank you.
Yep. So those are the kind of things that, these sessions, there's only so much we can cover in a couple hours and do practice questions and kind of talking through the practice questions. So there's going to be stuff that you guys are going to have to go back and review and look at. If you're not familiar with tetracycline, this is just a brief overview. And this is what I found to be important, and what I see in practice is what I'm passing on to you. But again, like the person said, they interact with milk and acids. A lot of your microbials do. Any other questions? All right, are you all ready to do some practice questions? So the nurse is caring for several clients receiving antivirals. Which client finding requires priority intervention? So that means it's a priority question. So what is going to be the worst or the one that is the sickest?
Option B. B as in boy.
B as in boy, urine output.
Yes. B as in boy, right? So if you weren't sure of that, look at the other complications. Does dizziness can cause syncope, but it doesn't always do that. Decreased urine output is a sign of kidney dysfunction, right? That's how we monitor it. That's how we measure it. Fatigue, while it may be uncomfortable and irritating for a patient, it's not going to be very harmful to them. And then a mild rash, if it's mild, it's not any, severe big deal, versus the decreased urine output is going to be one of the first signs of renal impairment. A nurse is reviewing a client with gentamicin. The nurse understands that the primary mechanism of action of the medication is to what?
Inhibit the bacterial cell wall synthesis.
Inhibiting bacterial cell wall synthesis.
So is it bacterial static or bacterial cytal?
C come first. Sidles. Oh no, yeah, sidles.
Yes, gentamicin is bacterial cytal.
Bactericidals, yeah.
So we want it to inhibit that bacterial protein synthesis, not just the cell wall, right? It's going to permeate that cell wall to then get to that protein synthesis, kind of like the nucleus of that cell wall. So that actually the answer choice is B. It's going to inhibit that bacterial protein synthesis, which is then going to lead to bacterial death. Inhibiting the bacterial cell wall synthesis applies to your penicillins and your cephalosporins. And then your folic acid synthesis is a characteristic of your sulfonamides. And then your fluoroquinolones are going to interfere with the DNA replication. Everybody get that?
Do you have any idea if we don't know the name of the medicine and we need to answer on the NCLEX?
Do I have any idea if you need to know the name of what?
I mean, in the NCLEX, we don't know what kind of medication gonna come.
No.
So if we need to choose, then what do we choose? Then it might be better to not do anything.
As far as what medications might be on there?
No, I mean,
I
we know
think
that there might be a lot of medication which we
There is a
even
lot of
doesn't know the
medication.
name. Yeah, we even doesn't know the name. So if there is any kind of antibiotics and antiviral, what will be the best answer to choose for all of those? The common answer.
So I really can't answer that because that's very vague. So the best way is to practice like test taking strategies, kind of like what we just did with this question. There is a lot of medications on NCLEX. NCLEX has increased you look at your NCLEX categories and it tells you how many questions you have under each category. And they have 18 to 20% under farm and parental, but they can also throw in medications under basic care and comfort, risk reduction. So there is a lot of medications. Breaking it down, kind of like we just did with this question. What do we want? Gentamicin, we know, is a very strong antibiotic. So that protein synthesis is what's gonna, the cell wall is just that, the cell wall, right? Like our skin is our cell wall. We want to get to the inside and break up that protein synthesis. So I just kind of went through why some answers are incorrect and why some are correct. So when you're studying, my suggestion, especially when you're studying pharmacology, is to read the rationales of why the answer is correct and then read the rationale for why the answer is incorrect as well.
Ma'am,
Yes.
I have a quick question here. Are we expecting this kind of question on the NCLEX, like primary mechanism of the medication kind of?
Yeah, you can expect to have those questions on NCLEX, yes.
Okay.
Because as a nurse, if you're giving a medication, do you need to know what the mechanism of action is and what it's going to do?
Yes.
Yeah.
I mean, like those proton inhibitors, like we will be looking into the acid and like, the inhibit acid, stuff like that. But this one is more like into the bacterial protein synthesis. So I was just wondering, like, if this particular like DNA replication kind of would be expected in the NCLEX.
Yes.
Okay.
You
Got it.
might see a question like this. Yes.
Thank you.
So all of these questions come from, I don't make these questions up, but all of these questions come from the NASLEX test bank, which are actually replicated questions of NCLEX. They're obviously not going to be the exact questions, but I can change this. I can change one word of this question and make it a different question. So it's really understanding the concepts of the content. If you look on the NCLEX website, you'll see exactly, when I talk about the NCLEX categories, you'll see exactly how many questions are going to be under each category. So this, and also your client needs, and also it breaks it down for you. Also your nursing process. So this would be the planning stage of your nursing process. You need to be able to know what this medication is going to do in your plan to go give it to the patient. Does that help?
Yes, thank you.
A nurse is caring for a client on tetracycline for acne vulgaris. Which instructions should the nurse provide to a client taking this medication?
Number B.
I would say B.
Yeah, expose of the sun.
B. No. Take antacid. No antacids. Nothing. No. So it's B. Avoid sun exposure during
Yeah.
therapy.
B, the sun exposure.
B.
Yeah. So they should avoid sun exposure during therapy. We don't want them to take it with milk because milk contains calcium and can inhibit the absorption. We don't want them to take antacids immediately after dosing. They need to wait 2 hours before or 2 hours after taking it. And we never want them to stop the medication once their symptoms have resolved. They need to complete the whole course. So this question would fall under, it could fall under farm and parental, or this could be a question that they would put under risk reduction, or they could use a question like this under management of care, because you're managing the care of this patient who's taking a medication. See how that works? A nurse providing discharge instructions for a client prescribed oseltamivir, which is Tamiflu. Which of the following should the nurse include? So this is a select all that apply question. So there's more than one answer choice.
B and C.
A and C.
D and D.
A and C.
So the correct answers are A and C. They need to start taking the drug within the first 48 hours of the symptom onset, because remember, it's ineffective after that. Notify the provider of any confusion or hallucinations. Those are going to be adverse side effects, or they're actually side effects, but they're rare side effects. So they could be dangerous to this patient, especially if the hallucinations are telling them to do something to harm themselves. So we definitely need to notify the physician. If you weren't sure of those answer choices, ask yourself which of the following should the nurse include. So if A is just pretty much a standard common knowledge with Tamiflu. If you didn't know about stop taking the drug if your fever persists, well, they may have a fever with the flu, right? That's one of the biggest symptoms. So we're not going to tell them to stop taking the medication. That's what the medication is there to treat, the symptom of the flu. Treat the flu, which provides or causes the fever, which is a symptom. So we don't ever tell patients to, well, I won't say ever, But very infrequently do we ever tell a patient to stop taking a drug if they have a persistent fever. The only patients that we might tell to do that would be your chemotherapy patients, because then it's a sign of infection. We're not going to keep giving them chemo, right? Notify the provider of confusion or hallucination. We said that was correct because that can be harmful. Take with grapefruit juice to reduce nausea. Well, kind of think about that one. Grapefruit juice is acidic. Is that going to reduce nausea? No, it's not. And we do know that grapefruit juice interacts with a lot of medications. So that's probably not going to be a correct answer. And then take with high fat meals to increase absorption. High fat, we really don't want patients on high fat meals, right? That's really not gonna, that's one of those, I call that a do nothing answer choice. It, we don't want patients on high fat, right? Was that kind of helpful talking through it?
Yes.
Where can we get the rationale for these questions? We're going through the rationales right now. The rationales are on the NASLEX website because that's where these questions come from. And that's why I go through the rationales of why the answers are correct or incorrect. Yeah, I am giving you the rationale verbally. A nurse is caring for a client on gentamicin for peritonitis. Which of the following adverse effects should the nurse monitor for?
Autotoxicity.
Hepato and auto. I mean, hepato.
C.
Autotoxicity.
C. It should be autotoxicity and
Oh yeah,
nephrotoxicity.
autotoxicity and renal toxicity. So autotoxicity.
Yeah. So the answer is C. It's ototoxicity. Remember, your mycins cause ototoxicity, nephrotoxicity, and neurotoxicity. So, photosensitivity, is that really, that's kind of an oxymoron. We have the word adverse effects. Is photosensitivity really going to be harmful to them? When I think of adverse effects, it's something that could be dangerous to the patient, right? Photosensitivity, while it's uncomfortable and irritating, it's not going to harm the patient, right? So I'm going to kind of throw that one to the wayside. Hepatotoxicity, I could see that, but knowing what we know about gentamicin, it's ototoxic, nephrotoxic, and neurotoxic. So I would go with the ototoxicity, which is the correct answer. And how are we going to monitor for that?
This is for hearings or tinnitus.
Yeah, if they start to complain of tinnitus, the ringing in the ears, or if they're
Dizziness.
starting to turn the TV up, or if you're having to talk louder for them to hear you, they could be developing signs of ototoxicity. And they can develop to hearing loss, which could be dangerous for the patient. Bone marrow suppression, it's typically associated with your antiviral medications and not your antimicrobials. A client presents with signs and symptoms of urinary tract infection. The nurse expects the healthcare provider to prescribe which of the following diagnostic tests to determine which organism is causing the infection.
Urine culture.
Urine culture.
Yep, urine culture. Absolutely. We may do a CBC to get the WBC, but that's not going to tell us what kind of organism. That's just going to tell us if they have an infection with that elevated white count. The creatinine is going to tell us what? What their renal function is, right?
Also the gravity of the urine, yeah.
And the specific gravity has nothing to do with what type of organism. A client is prescribed ketoconazole. Which of the following instructions should the nurse include?
ACD.
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 Okay, so what type of medication is ketoconazole?
Antifungal.
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 Mm.
Yeah, you're right.
Antifungal.
So do we need to avoid the sun with your antifungals? We don't. The biggest, what should be included is A and D. Report dark urine or yellowing of the eyes, because that's a sign of jaundice, which is that hepatic dysfunction, right? And D, avoid alcohol while on this medication. Taking with grapefruit juice for better absorption. Again, we kind of talked about that with the previous one, that sorry, grapefruit juice kind of interacts with a lot of medications, and we don't typically tell patients or educate them to take it with grapefruit juice. And alcohol can increase the hepatic workload. So we don't want them taking alcohol, and alcohol does interact with a lot of medications. And then stop the headache if a headache, stop the medication if a headache occurs. Well, again, it depends on the type of headache, and headache is not typically a side effect of your antifungal medications. A nurse is educating a client prescribed penicillin for a bacterial infection. Which of the following should the nurse include in the teaching?
ACE.
ACE.
I say A and E. Let me see. This medication.
ACE.
Mm-mm.
They play.
So the correct answers are
ACE.
A and C.
Oh,
Complete
and.
the antibiotics even if the symptoms improve, and this medication may cause diarrhea. So stopping the medication if you feel nauseous, we can combat that nausea. What are some things we can tell them to do to combat that nausea?
Take Zofran.
Take with food, drink a little ginger ale.
Crack rum.
Do what? If they do alternative therapies, we could tell them to get some ginger, because ginger helps with nausea. So it's not necessarily a reason to stop taking the medication. This medication may cause diarrhea. We said that was correct. Penicillin is safe to take with any other medications. Well, that's not true, And that's one of those all or nothing. That's saying you can take it with anything. Well, you can't, right? So they need to use it with caution with particular medications, especially those oral contraceptives, because it decreases the effects of those oral contraceptives. And then there is really no interaction between alcohol. I'm sorry, they should be avoiding alcohol while they're on this medication.
So why is that not right?
Answer correct or not, Professor?
Then that should be a correct answer too.
That's right.
Yeah, they did not mark it as correct. They should not be drinking alcohol with this medications. Yeah. So I'm gonna have to send that to them. Like I said, these questions come to me, and they're off the NCLEX, the NASLEX, NCLEX question bank. So a nurse is caring for a client with HIV who is on zidovudine, AZT. The nurse should monitor for which of the following adverse effects. So this is
Hyperglycemia.
The C.
Bone marrow suppression.
bone marrow suppression. Yep. Why do we need to monitor for bone marrow suppression? Because these patients, bone marrow suppression could cause neutropenia, it could cause anemia, it could cause leukopenia, which could further, they're already immunocompromised, these patients. It could further it. Hypertension, while it could be dangerous, the bone marrow suppression with the HIV, because they're already immunocompromised, is going to be a more correct answer. We don't want them to be hypertensive or hyperglycemic, but that's not in relation to the HIV itself. So you see how that bone marrow suppression can put an already immunocompromised patient at greater risk for immunocompromise. Is that helpful?
Yes, very.
Yes.
Yeah.
So ketoconazole does cause photosensitivity, yes. And patients on it should be advised to wear sunscreen. But that question was pertaining to adverse effects. So photosensitivity, while it is a side effect, it is not an adverse effect. Does that make sense? Okay. So be careful when you're looking at the wording of the questions, because like I said, those keywords are in the questions. Sometimes it's just test taking strategies, which I'm trying to help with here. A nurse is caring for multiple clients on antibiotics. Which client should the nurse assess first? So this is a priority question. So we want to look at airway, breathing, and circulation. Do any of these patients have an airway, breathing, or circulation problem?
Yeah, the one with the
E.
red blood
The
cell.
one on red man syndrome.
Oh, yeah.
Yep.
Yeah.
That's circulation all over the place, right? So the answer is B, the red man syndrome. Clients on cephalexin reporting nausea. Again, nausea is a symptom. Nausea is a symptom. I've never known anybody die or have an adverse effect to nausea. They may think they're dying, but they may act like they're dying with their vocal hysterics, but nausea, while it's uncomfortable, it's not bad. It's not going to harm them, right? Clients taking doxycycline complaining of photosensitivity. Well, we know that's going to happen. So we can tell them you need to wear sunglasses, you need to wear sunscreen when you go outside. And azithromycin who has a mild headache, the key word there would be mild. If they said they had a severe headache or the worst headache of their life, then that's going to be somebody you're going to see pretty immediately. But the red man syndrome, the vancomycin, and that flushed face, we need to see that patient first. A nurse is caring for a group of clients. Which of the following clients should the nurse expect to receive antimicrobial therapy? Select all that apply.
CNE. CDNE.
BDE.
ACE.
So the correct answer choices are A, B, C, and D. So let's talk about this. A is a client who reports being exposed to a sexually transmitted disease. We know with STIs, the person who is diagnosed with it, as well as anybody that they have had sexual relations with, needs to be treated. So that would be correct. A client who is having orthopedic surgery, those patients are at great risk because we're putting something into their body more often than not, and it's a very high risk surgery. We give prophylactic antibiotics. A client who has recurrent urinary tract infections, absolutely, right? We have to get rid of those organisms that keep recurring. That person is probably not taking the complete course of those antibiotics. And then a client scheduled for dental work this week, they may be put on those antimicrobials because of their history. A client diagnosed with an upper respiratory infection doesn't say if it's bacterial or if it's viral. Most often, your upper respiratory infections are going to be viral. Your sinusitis, your those type of infections. I just drew a blank. I'm sorry. The nurse has just administered an antimicrobial agent to a patient. For which of the following symptoms should the nurse identify as an indication of anaphylaxis?
Okay, A, C, D, E.
ACE.
ACD. ACD.
ACD.
A, C, D.
I hear AC and I hear ACD.
ACD.
A, C, D, E.
CDE.
Okay, good. Somebody finally gave me the E, right? So the answer choices are A, C, D, and E. A rash could be the first signs of an anaphylactic. Pruritus is that itching with that rash. We don't typically have itching without a rash on it. Wheezing, absolutely. And then stridor, absolutely.
So, Professor, please, what's the correct answer?
I'm sorry?
What's the correct answer for this question?
Well, we're talking through the correct answers right now. A, C, D, and E.
Yes, thank you.
So a fever is not going to cause an anaphylactic reaction. Remember, a fever is a symptom of something else. And then pain at the injection site is definitely not a sign of anaphylaxis. A client prescribed IV ampicillin for a bacterial infection suddenly reports shortness of breath and develops hives. Which action should the nurse take first?
Stop the antibiotic infusion.
Stop the antibiotic infusion. The key word for this question is it's IV, right?
Yep.
So we got to stop that medication from going because we know if it's IV, it's going straight into the bloodstream and they're just going to keep getting it. So, what would be our order of priority for this question? After we stop the antibiotic infusion, what are we going to do next?
You notify the healthcare
Give.
provider.
Notify the
Yeah, notify.
Notify the
assess the
healthcare
patient.
provider, right? Because we need that order for that diphenhydramine. But diphenhydramine, what do we treat an anaphylactic reaction with?
EpiPen, epinephrine.
EpiPen, yeah.
Epinephrine.
The epinephrine is going to be the first line drug, not the diphenhydramine, right? So we need to call that doctor. And then we're going to document. A client receiving acyclovir IV for a herpes simplex infection develops decreased urine output and elevated creatinine levels. What is the nurse's priority action?
Report the findings and hold the next dose.
Absolutely.
The findings.
Absolutely.
Right
So we're
now,
going to hold the next dose and report the findings. We're not going to take it upon ourselves to increase fluid intake. Assess for signs of superinfection. Well, an elevated creatinine and decreased urine output are not signs of superinfection. And we're absolutely not going to administer the next dose at all because this medication is causing this patient some renal failure, whether it be acute or now we need to figure it out or talk to the doctor to order more tests and see what's going on.
Professor, can you go back to the question before that one? Go up again. Oh, wait, go down. I'm sorry, down. Yeah, can you explain the answer again to me, please?
Well, this patient is getting this medication IV and it's going straight into the bloodstream. Now they're complaining of shortness of breath and they have hives. So what is that indicative of?
An allergic reaction that
Right.
threatening.
Right. So what would you do? What would you as the nurse do?
I would stop the infusion.
Yeah, that was the correct answer.
I thought it was notify the healthcare provider. I'm sorry.
No, it was stop the infusion and then I asked to put it in priority order because you may see a question like this and you have to put it in the order of priority.
Gotcha.
So I just turned the question around after the students gave the correct answer choice.
Okay. All right. Thanks.
Is there a
Yep,
difference
you're welcome.
Is there a difference if it was a power drug?
The nurse receives a report on 4 clients. Which client should be prioritized for assessment? So that's saying which one should she see first?
a client with on IV
D.
vancomycin with decreased output.
Yep. The client on vancomycin with decreased urine output. Because what is one of the biggest side effects of vancomycin?
Nephrotoxicity. Nephrotoxicity.
So vancomycin is nephrotoxic.
Nephrotoxic, yeah.
Yep, and decreased urine output is how we're going to measure that. If you were to put these in priority order, who would you see next?
A, B, then C.
So I would probably see B, client on acyclovir with a mild headache, because if we're talking priority airway, breathing, circulation, and disability, disability is your neuro status. I would see the mild headache. It may be nothing, but then it may be the start of something. And then I would see the client on fluconazole with the elevated, slightly above normal AST and ALT. And then I would see the client. I probably wouldn't even have to see the client on the Tamiflu started within 48 hours, because that's when it should be, right? Does everybody see that? The nurse is reviewing the pharmacology of antibiotics. What is the primary action of microlides, like azithromycin?
They inhibit bacterial cell wall formation.
A, disrupt bacterial DNA.
What is it?
They inhibit bacterial cell wall formation.
So it's not gonna inhibit the cell wall formation, because that cell wall is already formed. It's gonna inhibit the bacterial protein synthesis. Answer choice B. Our penicillins and our cephalosporins are what inhibit that bacterial cell wall formation. A client taking acyclovir asks how the medication works. What is the best response by the nurse? So what type of medication is acyclovir? What classification is it?
D.
Viral.
Viral.
Antiviral, right?
And the answer is B.
So what's our answer choice?
B as in boy.
Yep, B as in boy. It inhibits that viral replication. It does not destroy the virus completely. It does not strengthen the immune response, and it does not block absorption of the virus in your gut. That's kind of the virus doesn't go in the gut, right? So that's just a thrown in there answer choice. A nurse is caring for a client on fluconazole for a fungal infection. Which of the following lab tests is most important to monitor?
The potassium for the hypokalemia.
So, does your antifungals affect your electrolytes?
Yes, the potassium because of hypokalemia.
I don't know that your antifungals are going to affect your electrolytes. The actual answer choice is C because fluconazole is metabolized in the liver. So we need to be monitoring those liver enzymes, making sure that it's not causing or worsening any liver dysfunction. It doesn't affect the hemoglobin or the potassium or the platelet count either. Does everybody see that? I don't know why this keeps doing that. A client receiving IV penicillin develops sudden dyspnea, wheezing, and hypotension. What is the nurse's priority action?
B, stop the infusion.
Stop the infusion. Yeah. Stop the infusion. That's kind of a given question. A nurse is educating a client on Tamiflu. Which of the following instructions should be included?
A and C.
A and C, yep. We don't stop the medication if nasal congestion occurs. Again, high-fat diets are typically not what we're going to tell patients to follow. And we're not going to tell them to stop it if their symptoms improve. A nurse is caring for a client on amoxicillin. Which of the following findings indicate a possible allergic reaction?
A and C.
A and C, yep. They're not going to have hypertension with an allergic reaction. They're more likely going to have hypotension. They may have bradycardia later on, but initially they're going to have tachycardia. And joint pain isn't related to an allergic reaction. It could be a side effect of some medications, but not typically an allergic reaction. A nurse is educating a client on erythromycin. Which of the following instructions should the nurse include?
CD.
CD.
Yep, C and D. Absolutely. Does everybody see that? Most of our antibiotics are supposed to avoid, or we educate them to avoid antacids at least 2 hours before and 2 hours after. And antacids don't necessarily help them avoid GI upset. And then crush the tablet if it's difficult. Well, it depends on what type of tablet it is. And then continue taking a torvastatin. There's no interaction between those medications.
Bella.
So that is all I have for tonight. What questions do y'all have?
Thank you, Professor. When is the next class?
I'm sorry?
When is the next class?
Can y'all mute? I'm not able to mute people. Unless you're speaking, can you mute, please? My personal next class?
Yes, Professor.
My next class, I believe, is next Tuesday.
What is it gonna be on?
Let me pull that out for you. I just wrote it all down. Shoot. So my next class is the 10th. And it's on no, that's today.
Teacher, can you
My
share the document, please?
The documents are shared on the NASLEX website. My next class is the 24th on neurological pharmacology.
Great, thank you.
You're welcome.
Do you do group tutoring? I mean, I know you said you were getting ready to start tutoring. Do you do group tutoring or is it just one-on-one?
Well, this is kind of group tutoring. I have not, they haven't gone forward with the individual tutoring yet.
Okay, thank you.
Thank you for your time, Professor.
Thank you, guys.
Thank you so much,
Thank
Professor.
you.
Very informative. Thank you so much.
We appreciate
You're
you.
welcome.
Thank you, Professor.
You're
Thank you,
welcome.
Professor.
Get some rest, Professor, and take care of your coughs.
Thank you.
Okay.
You professor.
Yes.
Professor, put some honey in your water. Okay? Honey is good.
Okay, I will do that.
So
My
let me-
problem is I'm sitting in my house that is under construction.
Oh, the dust.
I didn't have time to go back to where I'm staying before the class started.
Okay, it's all that dust, right?
Yes.
Yeah. Okay, feel better.
Thank you. You guys have a good day or night.
Okay, Professor. Bye-bye. Just